Hey everybody! Today we're going to talk about the topics of sex and gender, the differences between the two words and the meanings of the words, and how as respiratory therapists, knowing the different ways different conditions affect our patients and therefore affect our jobs, and maybe some ways we can change the way we handle our patients and handle a more gender-based treatment for such patients. According to the World Health Organization, sex is defined as the biological and physiological characteristics of males and females, such as hormones, chromosomes, reproductive organs, and the things as such. Sex is assigned at birth. One can have a sex reassignment surgery when they identify as the opposite sex. On the other hand, gender is defined as a socially constructed characteristics of women and men, such as the norms, roles, and relationships of and between groups of women and men. It can vary from society to society, and it can change. Gender is more about identity and the way one feels, the way one identifies, not necessarily the sex of that person. People may self-identify as male, female. They can identify as transgender, or other, or none of the above, and that can be known as non-binary. Gender is associated with the behavior of a person, with the lifestyle, with life experience. As RTs, we tend to concentrate on things that affect the lungs. But many things we can do also bring into account the heart and the kidneys. Each one of these systems affect the way the lungs function properly. And if the heart and the kidneys are not functioning properly, then the lungs probably won't be functioning properly either. Lung cancer and chronic obstructive pulmonary disease remain a serious problem for both men and women. Because of the prevalence of women becoming smokers more today than they used to be, the instance of COPD in women is growing, whereas many years ago, you would have probably only seen lung issues in men worse than women. Now you see more in women. So we have to take that into account when we approach a patient in the ER or in our daily practice, or as we approach a patient on a floor at the hospital. The lack of gender-based prevention can cause us to ignore certain signs and symptoms, such as men and women can present to the ER with different symptoms of a heart attack. They can present with similar symptoms, but women tend to experience things like shortness of breath, pressure or pain in the lower chest or upper abdomen. They tend to experience things like dizziness, lightheadedness, fainting. Extreme fatigue may be something that a woman experiences, whereas a man can experience these same symptoms, but they will more typically show just the tight, crushing chest pain. Another important reason for us as RT to know what the sex of the patient is, not necessarily the gender, but your original or what you were assigned at birth, is for when we set up our ventilators. They ask us to pick male or female on our vent, and with that, they take into considerations the differences that may be there in the anatomy of the patient. It the ventilators will, as you know, pick a tidal volume for that patient for a male at a certain height or weight, or a female at a certain height or weight. It will determine your tidal volume for you. Something else we have to think about when we approach a patient. Say we are called to a patient's room on the floor, on the medical floor. The patient is hard to arouse. We ask, are they male or female? If they're male, we know that males have a 2 to 3 higher instance of having sleep apnea. So it could be something as simple as the patient has sleep apnea and they're harder to arouse because, as you know, their CO2 levels get higher, so it makes them harder to wake up. Men, and this tends to happen because men have larger nasal cavities, and have increased instance of that upper airway collapsing or closing when they relax and go to sleep. This is why we see more snoring in men, and the higher instance of sleep apnea in men. Women with AFib tend to receive less anticoagulation therapy, and they tend to have a higher risk for stroke than men do. Women tend to experience more strokes than men do, and many of those are attributed to our AFib. So when we go in to do an EKG on a patient and the patient's in AFib, we need to make sure that the physician sees those EKGs so they can know to check, especially if they're having different issues or different symptoms that comes with possible stroke or comes with possible blood clots. Those can be contributed to that. Taking our patients at face value and all of their complaints is one of the best things we can do. When they say something is wrong, we don't look at them, especially we don't look at women, and just think that they're having an emotional moment. We need to find out what's wrong with them. Training our staff can be a very important tool when it comes to gender-based medicine. Knowing how to treat either sex and the best way to do so is very important. Knowing the signs and symptoms that are specific for diseases or conditions that can be specific for a specific sex. There are signs and symptoms for certain conditions that can be more prevalent for men or in other instances more prevalent for women. Training our staff to know how to approach questions to get when you come to a patient that identifies as male or female, but that is not their not the sex they were born with. There are issues that can be affected. There are conditions that can be affected by hormones or chromosomal issues, and being able to figure out the sex of a patient sometimes can determine what is wrong and what testing you do for a patient. Just knowing how to approach our patients, no matter the sex, and knowing how to assess our patients is the best way to tackle gender-based medicine.